Sir, in relation to your recent talk in the CSI 2017, I would like to understand from you for left main revascularization, what is the current place of FFR?
See, at the outset, we must understand that angiogram in its present form has its own limitations, because an angiogram is basically a 2D image and it's basically a luminogram. So, to define if a lesion is significant or not, we use an arbitrary figure. The left main, we say it is around 50%. But this 50% is not a holy grail, in the sense there may be lesions that are 45% that are significant. There may be lesions that are 55 or 60% that are insignificant. So here comes the concept of functional significance, and that is where fractional flow reserve comes inside. So it is mandated that in intermediate lesions, that is a lesion between 25% to 60%, we must do a fractional flow reserve to find out if this lesion is significant or not. Otherwise, in a patient where angiographically it may look it's 50 to 60%, but actually the lesion is not functionally significant, if you do revascularization, it may not benefit the patient.
Right, sir. So, sir, according to you, what will be the place for IVUS?
Intravascular ultrasound has now come out to be a very important imaging tool, and these are imaging tools that are primarily used to optimize stenting. In the left main, IVUS is absolutely essential to find out if your stent has been apposed well, if your stent has left any dissections, if your ostium is well covered. It helps in 3 areas, if you look at it basically. Pre-intervention helps in planning the intervention. For example, if you detect a lot of calcium, you can use a cutting balloon or you can use a rotablator. Immediately after stenting, you can define if your stent has been well expanded, if there are any residual stenosis left. And it has been shown that optimized left main stenting using intravascular ultrasound can decrease mortality by close to 40 to 50%. So, to the question, is IVUS essential if you plan to do a left main revascularization or a left main stenting? I think the answer would be yes.
Right, sir. So, sir, as you said, IVUS is now essential for left main revascularization. Do you think that this IVUS criteria can be applied as it is for the Indian population, or we do need some kind of modifications?
That's a very good question. Intravascular ultrasound has defined some criteria to find out if your left main is significant. The Spanish and the Americans have said it's roughly around 6 millimeters square. While from Asia, from Korea, Dr. Park has put that figure as 4.7. Now, what exactly is it in India? We are not too very sure. However, I think we must caution here and say that I think putting an absolute figure and saying that less than this, the left main is significant, I think is erroneous. Because some people have large coronaries, some people have smaller coronaries. So, one figure does not fit all. We have a second set of figures to tell us a 5, 6, 7, 8 rule. In other words, if you do a left main stenting, you must at least try and attain an 8 millimeter square area in the left main post stenting. At least, that's the word. But again, there is data to show that if it is less than 8, you get greater events. But again here, this is not an Indian population. We do not have data in the Indian population, to put it frankly. So I think the answer would be close to somewhere in between, because in my own experience, in our own practice, we have found that most of our left mains actual size is more than 15 to 18 square millimeters. So I think we must try and attain at least a 6 millimeter square or more in the Indian population. Our left mains are not, as we believe, smaller than the Western population. Of course, that's what my anecdotal experience is, but of course, we don't have data on that.
Right, sir. So, sir, what will be your final key message to the Indian cardiologist for left main stenting?
See, my message is that If you have an intermediate left main lesion, I think we must do a fractional flow reserve to determine if that lesion is functionally significant before we decide whether we should send the patient for a bypass surgery or an angioplasty. I think it's part of the appropriateness of a left main revascularization. Secondly, I believe that if we plan to do a left main stenting, you must optimize the stenting using intravascular ultrasound. I think it would decrease your morbidity, decrease mortality, and increase their long-term outcome results.